Our next speaker is Dr. Jeff Perry, who is a full professor in the Department of Emergency Medicine and the School of Epidemiology and Public Health at the University of Ottawa. He serves as the director and senior scientist of the Acute Care Research Program at the Ottawa Hospital Research Institute and is an attending physician in the emergency department at the Ottawa Hospital. Recognized internationally for his expertise in clinical decision rules, Dr. Perry has authored over 275 publications. He co-founded and served as the inaugural chair of the Canadian Network of Emergency Research, or NICER, an initiative dedicated to mentoring new investigators and advancing large-scale multicenter studies. Please welcome Dr. Perry to present prospective multicenter validation of the abbreviated Canadian TIA score for predicting subsequent stroke within 7 days.
Okay, great. And most importantly, missed out that I'm currently Ian's boss. So it's truly a pleasure to be here today to present the results of our study on the validation of the abbreviated Canadian TIA score. I'd like to acknowledge my co-investigators, several of whom are here in this room. So thank you very much for this, for being collaborators. And I'd like to acknowledge funding from the Canadian Institutes for Health Research, which is peer-reviewed funding, and I have no conflicts of interest to declare. So transient ischemic attack, TIA, it's very important as it precedes 15 to 20% of all strokes. This is an opportunity to prevent subsequent stroke with intervention early so that they don't have the permanent disabilities or death associated with stroke. Existing work prior to our scores were very context dependent, didn't validate well, so more work needed to be done. We have previously created the Canadian TIA score, or the full score, both validated and, derived and validated, but it was quite complex. It had 13 variables. So why is this important? Well, without us intervening, we know that about 10% of patients will have a subsequent stroke by 90 days with very minimal intervention. Most of that is to the right of this graph where it's front end loaded. They happen within days. You'll notice after about 7 days, this slope begins to flatten out and continues very slowly after that. With optimal intervention, you can get this graph to basically be about 1% at 90 days. But it's up to us to identify who's at high risk, intervene early and maximally to give better outcomes for this patient population. But you can also see that most of the patients do well without us doing all this work. So it's very inefficient to maximally intervene on all patients. But who's at high risk? Who do we choose to invest in to figure this out? So again, we've embarked on a series of studies looking into this problem, and what I'm going to talk to you today is about the last part here, the validation. So as mentioned, the full Canadian TI score has been fully peer-reviewed, it's published, it does work, but it's a bit complex with 13 variables. So what we did is we took the information where we developed the Canadian TI score, both the derivation and validation, so about 11,000 patients, and used newer statistical techniques to come up with a model that basically has 5 variables rather than 13. Given that there's a lot of statistical manipulation, this needed to be revalidated in a new patient population to make sure it just wasn't by statistical chance and that it was real. So the objective of this study was to prospectively validate the abbreviated Canadian TIA score in a new cohort of emergency department patients with TIA or non-disabling stroke. So this is what our original score looks like, the full one, versus our newer one, where if you look just here, you can see there's 4 clinical variables: past history of carotid stenosis, history of unilateral weakness, vertigo as a negative predictor, and dysarthria or aphasia, so language disturbance as one. We also looked at imaging, whereas if you had an old infarct, you had 1 point, acute infarct, 2 points. You can only get a maximum of 2 points for imaging. And this correlated with the score on this side here, where essentially you had low, medium, and high risk with point ranges between -2 and 8. So this was a prospective cohort study, 14 high-volume Canadian emergency departments, where we looked at the components of both the full and the abbreviated score, both individually and as a whole. We had our doctors complete our data collection forms prior to knowing what the outcomes were, so prior to ED disposition, whether they were referred to a neurologist or referred as an outpatient. We also tracked investigations and admissions. Our outcome was subsequent stroke within 7 days or vascular reperfusion of the carotids within 7 days. And this was adjudicated by local adjudication committees comprising of 3 experts. Our analysis included interval likelihood ratios, C-stat sensitivity specificity, and our sample size was 4,000 with at least 100 events. So why carotid revascularization? Well, there is previous work showing an NNT of just 3 if there's carotid stenosis that's responsible for the presenting complaints or the cerebral ischemia of 70 to 99%. And the NNT is still quite significant, even in the 50 to 69% at 7. So that's why we kept these patients in, because if we didn't include them, the rule may not function well in places where they're not able to get this intervention quickly. So in terms of our flow, we were able to enroll basically 88%, 4,500 patients, including 142 outcomes, with very few patients lost to follow-up, just 35. This correlated with an event rate of 3.1% at 7 days and up to 4.3 at 90 days. So you can see that's less than the 10% that I showed you at the beginning. So what we have been doing as a community is reducing our events, but still not at the optimal 1% range that we know from previous work we can get to. So focusing on this slide, essentially we were, with the abbreviated Canadian TIA score, we were able to classify 26% of patients as low risk. So these patients had event rate less than 1%, very high sensitivity of picking up events after this, and essentially we were able to push over a quarter of the patients into a low-risk category. For the medium risk is 62% and high risk as 11%, and this correlated with a very high specificity. Looking at the full rule, again, we were able to better reclassify patients because this only had 16% as low risk. Still functioned well, still is correct, but it just doesn't discriminate as well as the abbreviated Canadian TI score. In terms of our interval likelihood ratios for the low risk group, it was significant at 0.24 with an observed risk of, again, less than 1% event rate. And this was combined, I'm not showing you the group with just stroke alone, which we did look at, but they performed even better than with our composite outcome. With the medium risk, it was an interval likelihood of 1, so we still don't really know what's going on. They had an event rate of 3.3%. And the high-risk group was, the interval likelihood ratio was 2.8, statistically significant, and observed risk of almost 9%. So a few points for discussion. First off, the score was successfully validated in this new cohort of TIA minor stroke patients. We believe it is ready to use clinically. In terms of recommended steps based on these stratification, it'll depend on how much resources you have available. Our investigator group, which included both neurologists and experienced emergency physicians, thought that low-risk patients would require a CT head if available. It could be slightly delayed if the patient's now asymptomatic and low risk, but not appreciably, so maybe the next day kind of thing. An ECG, looking for atrial fibrillation or flutter. Starting antiplatelet, probably just single agent would be fine. or anticoagulant if they have a history of atrial fibrillation or flutter, or you find that they're in that arrhythmia in the emergency department, and outpatient follow-up. Medium risk, these patients are at higher risk. They should get a CT head and vascular imaging during that index visit, whether it involves a transfer or not, if your site can do it or not. An ECG, dual antiplatelet therapy for most patients, anticoagulation, again, if they're in atrial fibrillation or have a history of atrial fibrillation, and early outpatient stroke prevention clinic follow-up, or with an expert. For high risk, be very similar to medium risk, except we suggest you have a conversation for most of these patients with a stroke expert during that index visit to make sure that everything possible is being done immediately to optimize their stroke prevention. Some limitations, well, we still need to do an implementation study, find out if we do what we're suggesting here with our risk stratification, do we move the needle? Do we improve outcomes in terms of subsequent stroke or vascular death? We suspect we will, because we're identifying the highest risk, but we don't know that yet. There were a small number of lost to follow-ups, just 35. They could have been caused some misclassification, and there was different care provided because we had different sites. We had different physicians within those sites, so the care was not standardized as a cohort study. So in conclusion, the abbreviated Canadian TI score is ready to use. It is much less complicated with just 5 variables versus the full Canadian TI score. This provides a tool to help stratify patients in resource-limited environments, and we're able to identify more than a quarter of the patients as being low risk, which require much less resource intensity for their care. It also identifies a group of just over 10% that are the highest risk, where we should intervene and do the best we can to prevent subsequent events. I'd like to thank our emergency research staff, and I'm happy to answer any questions if we have time.